So there were 20 questions in MIQ, and if you are able to get more than or equal to 15 out of 20, it means you're doing good. Wait, let me log in again. Out of 20. Yeah. It means. Alright, fine. Okay, so now it's okay. So as I told you, more than equal to 15 out of 20 should be good. So let us start. There are 20 questions and we have 1 hour to finish them. And the first question, hi SK Tulsi Pooja Smiley. Okay, the first question is to identify the retina cell which is marked over here. So this is the animation of the retina, and there were 4 options as usual, and this was the cell which was asked. So if you know that this is actually animated patient retina, this is the retinal pigment epithelium, which is the last layer of the retina, and in contact with the RP there is some photoreceptors. Photoreceptors are rods and cones. This is the cones and this is the rods, because the shape of the cone is like a cone, like a softie. So this is your the rods and cones layer, which is the photoreceptors. Well, this is the rods and cones nucleus, and that nucleus is the outer nuclear layer. Whenever the word nuclear comes, outer is towards the choroid. So there is the outer nuclear layer of the retina, and in between the photoreceptors segments, the outer segment and the inner segment, this will be O means outer segment, I means inner segment, outer is towards the choroid. There is a external limiting membrane. In the visual pathway here, the impulse goes via this synapse. This synapse is, I am writing short form, outer plexiform layer into the inner nuclear layer. All these cells which are marked are inner nuclear layer, of which this are the bipolar cells, which was not asked. This is a amacrine cells, the yellow one. And the question which is asked is Muller cells. Now Muller cell, the nucleus is in the inner nuclear and it spans all throughout the retina. You can see the axons are from the inner limiting till outer limiting. That's a microglial tissue. It is a supporting tissue of the retina, and that was a question over here. That is a Muller cell. Amacrine is also, the nucleus is in the inner nuclear. Photoreceptor is the rods and cones, maybe segments, maybe the nucleus. In between the segment and nucleus there is a outer limiting membrane. Now ganglionic cell, from here the impulse goes via inner plexiform. Plexiform means synapse into, this is the ganglionic layer of the retina. And the ganglionic axons, the axons of the ganglionic is the nerve fiber layer of the retina, which ultimately forms the optic nerve. So that is the identification of the layers, and the first layer is a inner limiting membrane, which is not very important, which is formed by the foot processes of Muller cells only. So that's the identification of the first question. Any doubt in this, you can ask me now, because this question is a PYQ. It was asked in INICT, can be asked in NEET exam. In the animation version as well as in histopath, you can ask. In histopath, I have not given the histopath question. In histopath, the cells will be blue dots. So the blue dots will be ganglionic cell, inner nuclear, outer nuclear. These will be blue dots. And the RP will have a brownish melanin pigment, because RP means pigment is melanin, which is maximum at the fovea in the RP layer. So that is the first question, to identify the retina cell. I don't think so any doubt or any controversy in this. Okay, I told you how to identify the other cells as well in the first question. So 15 out of 20, right, should be the correct numbers. If you are doing that, it means you are doing good. So first question was this. Now second question is a clinical question. A 1-month-old baby was brought with the complaints of photophobia. And what is photophobia? Photophobia means patient is intolerance to normal light, like normal tube light, and there is a watering. Now photophobia, watering are present from this only. From this photophobia watering, we can rule out megalocornea, because megalocornea is only increase in the size of the cornea, no symptoms, no other symptoms are there. It's just a finding, increased size, no symptoms other than megalocornea, so that is ruled out. Clinical examination show normal tear passages, and normal tear passages rules out dacrocystitis. If there is a dacrocystitis, there will be regurg material and there will be regurgitation test positive. Means there will be regurg material from the puncta. So that cannot be the answer. Large cornea as in the figure. Now, large cornea can be there in primary congenital glaucoma and megalocornea, but megalocornea is ruled out. Now, corneal ulcer does not have this large cornea. So, even I don't show you the picture, the answer is clear. It is ophthalmos. That is primary congenital glaucoma, and this big eyes is known as ophthalmos. Quickly, if I just revise primary congenital glaucoma, why there is glaucoma, why there is photophobia, there is a triad, photophobia, watering, blepharospasm, because of high pressures. There is high pressures in the eye. Why? Because the anterior segment is covered by a membrane, that is Barkan's membrane, which is not allowing the aqueous to go outside. That is open angle mechanism or closed angle mechanism? It's an open angle mechanism. It's an open angle mechanism in primary congenital glaucoma because Barkan membrane is blocking the trabecular meshwork. So because of high IOP, there is irritation of the nerves. Nerves of the outer fibrous, cornea sclera, are irritated. That's why the patient has watering photophobia. And blepharospasm means squeezing eyes. And what are the other signs? The axial length will increase. Increased axial length means patient become axial myopia. There will be deep anterior chamber because eyeball size is increasing. Because of high pressures, the lens is flat. Because of high pressures, there will be compression of the lens. There will be weak zonules. And if the zonules are broken down, it can lead to subluxation. Dislocation means ectopia lentis. Lentis means lens. And here the cup disc ratio can reverse if you manage on time. And who can tell me the management? So much confusion is there in management. If congenital glaucoma management is asked, direct answer management is surgery, goniotomy. Goniotomy is cutting or cutting the Barkan's membrane. But if the patient has corneal opacity, if there is corneal haziness, you cannot do goniotomy because it is a angle surgery. You have to see the angle and cut. Then the answer is trabeculotomy. Lo means to open something, to open the Schlem's canal. And if in the question trabeculotomy and trabeculectomy comes together, which was a very old PYQ, it won't be asked now. So trabeculotomy plus lectomy, if in the one option, that's a better answer in any scenario in primary congenital glaucoma. Yeah, the sequence can be different. I don't know. I gave the sequence in this. Sequence can be different. There are 20 questions which are the same, which we'll discuss now. So primary congenital glaucoma surgery is goniotomy. Primary congenital glaucoma if corneal opacity, trabeculotomy. And any scenario with or without corneal opacity, if T and T, trabeculotomy plus trabeculectomy is there, that is the best answer in any scenario. And only these two surgeries can be combined. Very old PYQ, cannot be asked now. That's the second question. Any doubt in this question? Ask me. Third question is again an image question. Now see, all the letters are black color, but shape and size are different, means it is checking which sense of the patient. Form, color, contrast, light. Shape and size means it is checking the form sense. Now this is not Snellen's chart. Snellen's has top single letter. This is ETDRS. What is the full form? Early Treatment of Diabetic Retinopathy Study. Each line has 5 letters. And the size and shape is decreasing and it is done from 4 meters. That is the answer of this question. नहीं था ये क्वेश्चन ही नहीं था सेकंड वाला. ऑप्थल एमसीक्यू ऑप्थल के एमआईक्यू देकर आए हो ना कार्तिक है. मेडिसिन कार्ड ने दे दिया. ऑप्थल में तो यही थे. Now, what is the other thing? ETDRS, Early Treatment of Diabetic Retinopathy Study. The question has been asked as the full form, done from 4 meters. It is also known as logarithmic of MAR chart. It is based on log MAR, not MAR. Snellen's is based on MAR. ETDRS is based on log of MAR. That calculation is not asked. MAR calculation can be asked, yes. Now, it is better for amblyopias also. ETDRS is better chart for amblyopias because of which phenomena? Crowding phenomena. If you have attended the class, you might be knowing. Because the letters are in crowd together. If the letters are crowd, patients, amblyopia means lazy eye people cannot appreciate the letters in a crowd. So Snellen's will overestimate the vision of amblyopias. Because of which phenomena? Crowding phenomena. Yes, Karthik, I know. I have given them. मुझे पता है. मैंने दिए हैं तो question. तो थे वो तो. Alright, so each line, Karthik, has 5 letters. Okay, and the size and shape is changing. So it is ETDRS from 4 meters. Third question, any doubt on this? Snellen chart MAR, minimal angle of resolution, you should know. In Snellen's chart, the minimal angle of resolution is, for example, the visual acuity is 6 by 60. So MAR will be 60 by 6, 10 minutes. But the total letter will subtend, 5 segments are there. So total will subtend 10 into 5, 50 minutes. In ETDRS, we do log of MAR. Calculation is not us, so it is also known as log MAR chart done from 4 meters. So today morning, a student asked me, sir, in diabetic retinopathy, the first feature is what? And this question, first feature is microaneurysms, not dot hemorrhages. Microaneurysms are what? This is the capillary. It is a microangiopathy. So if there is a capillary and surrounding the capillary, there are cells known as pericytes. In early stages of diabetic retinopathy, there is loss of pericytes. If the pericytes are lost, the extravascular space will increase or decrease? Will increase. So this capillary can proliferate. This proliferation of any vessel is known as aneurysm. And it is a microvessel, it is a microaneurysm. There is a very subtle sign seen on, it cannot be seen on fundoscopy. Can be seen on red filter, but that is not of your level. So that's why it is seen on angiography. On angiography, it will be seen as, INI question, hyper or hypofluorescence. It will be seen as, you put the dye here, dye will also go into outpouching, and you can see the dye as hyper what? Dots. So hyper dots are microaneurysms. Only 2 signs are hyper in diabetic retinopathy at your level on angiography. Hyper dots are microaneurysms. Hyper branching is new vessels. So this will be very mild NPDR stage. Rest all the signs, dot hemorrhages, hard exudates, ischemic retina are hypofluorescence. Only 2 signs are hyper, very good Techi, microaneurysms and new vessels. Hyper dots, hyper branches. रट भी सकते हो, बुरी तरह भी रट सकते हो. Hyper dots and hyper branches. Hyper dots are microaneurysms, hyper branches are new vessels. Any new vessel will leak the dye, so you can see the dye coming out of the new vessel, and it's a videography. Videos are not asked in the exam. You know why I tell in the class also sometimes videos are not asked. Once they ask the video, वो चली ही नहीं एग्जाम में, तो तब से वो वीडियो नहीं देते, सिर्फ पिक्चर्स देते हैं. तो एंजियोग्राफी they give pictures, still pictures. In that, if there is a whitish there and whitish branching, that is a new vessels. That will be proliferative stage of diabetic retinopathy. Microaneurysms is very mild NPDR stage. So that's the B answer, B for Vinod. Who is Vinod? I don't know. Now, visual field question is very hot favorite. Many times this visual field question comes in the exam. A patient is not able to see from the lateral half of both visual fields. Now, if visual field is drawn like this, it has to be taken as a patient view. Patient view means you are the patient facing the screen. Patient is facing screen like I am now facing the screen. So this is my right visual field, this is my left visual field, and I can't see the lateral half of both sides like this. Means this is bilateral defects and bitemporal and hemianopia. Bitemporal hemianopia should be an easy question. It is present in optic chiasma. If the patient has right optic nerve, he will say that he cannot see from the right side only, right anopia. In left optic tract. So if the lesion is in the left optic tract, means behind the chiasma on the left side. This is the visual pathway seen from above. So if there is a left optic tract lesion, it will be left side, temporal fibers are not working. So left nasal field loss. And right nasal fibers are not working. So right temporal field loss. So patient will say, I will not be able to see from the right side from both eyes. That is left optic tract. But if the patient says, so many times FMG question, very important. If the patient says, I can't see from the right side from both eyes, but I can see from the center, that will be macular sparing. In macular sparing, it will be left occipital lobe because of additional supply from middle cerebral artery. That is a keyhole vision. Keyhole defects in LGB, keyhole vision in occipital lobe lesions. Okay, so visual field question is very important. It has to be taken as patient's view. Worth 4 dot test, Maddox rod, visual field. Has to be taken as patient facing the screen, like you are the patient. Okay, who can answer this question? If I draw a question for you, tell me where is the lesion? This is left homonymous. Homonymous means same side. Heteronymous is only optic chiasma. So this is in my question left homonymous inferior quadrant anopia. Pi on the floor. This will be seen in right side parietal lobe lesions. Because in parietal lobe the superior radiation fibers are passing, so inferior defects are there. Vice versa will be there in temporal lobe lesions. Pi in the sky. Good, Roshan. You should answer right parietal lobe. Exact answer is right parietal. Good. किसने आंसर किया ये? सबसे पहले खुशबू जी ने. Very good, खुशबू. So that's the third question. Any doubts in the visual field? Third question, let me know. Otherwise, glaucoma diagnosis is the fourth question. A patient has intraocular pressure of 26. It is high because normal is less than 21 of mercury. Cornea is thick, okay, fine, doesn't matter. Usually thick cornea gives false high IOP. If you know, you know. If you don't know, doesn't matter. But visual fields are normal and optic disc is normal. So visual field and optic disc is normal in primary glaucomas. We cannot call the patient glaucoma. Gonioscopy showed open angle. So open angle is there. So 3 answers are ruled out automatically. The only answer available is ocular hypertension. By only this you can get the answer, open angles. So it cannot be angle closure. It is ocular hypertension, which is an open angle mechanism. If the pressure is high, field is normal, optic disc is normal, that is ocular hypertension. That's the answer of this question. Now if it is a closed angle, then who can tell me? If I give the question, this is closed angle, then answer is what? Then tell me what is ABCD, what is the answer now? If the angle is closed, IOP high, normal field, optic disc, gonioscopy, closed angles, then answer will become primary angle closure. Here it is open angle, so that's where the answer is ocular hypertension. So glaucoma, 3 definitions, this is primary glaucomas. 3 definition in primary open angle spectrum, 3 definition is primary angle closure spectrum. Now identification of cataract and one question of cataract or complication of cataract is important, always a most important question. And patient is on systemic corticosteroid. Any steroid can cause cataract. More years, more duration, more chances of cataract. Which cataract? It can lead to this one, posterior subcapsular cataract. So it's a differential of PSC. I always says remember as BSC. From S is steroids. From B there is a drug, busulfan. B lowers cataract. And B blunt trauma. Now you will say, sir, blunt trauma has rosette cataract. Yes, rosette is one type. Blunt trauma can be causing PSC as well. Steroid is a very, very important example. And complicated cataract. Who can tell me complicated cataract? Most common example is what? Polychromatic luster, breadcrumb appearance, uveitis, any intraocular pathology, any inflammation, uveitis, dystrophy, degeneration will lead to complicated cataract. That is why retinitis pigmentosa associated with PSC. Any dystrophy, any degeneration, any uveitis starts as PSC. Cupoliform. Cupoliform is a senile cataract. And chloroquine. Chloroquine causes PSC. Chlorpromazine, antipsychotic drug, causes anterior subcapsular cataract. And systemic causes more of cataract, topical causes more of glaucoma. So polychromatic luster, breadcrumb appearance, complicated cataract, most common cause uveitis. Alright. Now patient, corneal ulcer question. A patient came to OPD with severe pain in the left eye. Uses contact lens. Now contact lens is most common organism with contact lens related keratitis is Pseudomonas. If you wash it with dirty water, then it will be acanthamoeba. But there was no much findings on examination. Means signs are less and symptoms are more. From here only the diagnosis comes. The diagnosis is acanthamoeba. In comparison to fungus, symptoms are less, signs are more. Dry, rough texture, feathery rolled margins, satellite lesions. These goes in favor of fungal keratitis. So acanthamoeba is the answer, and which is the culture medium for acanthamoeba? Many times question has been asked. Non-nutrient E. coli agar. Sabrur's agar for fungus. LG medium for TB, I think. Ther Martin also, I don't know for what, micro question, but this is non-nutrient E. coli for acanthamoeba. Signs are less, symptoms are more. Arfa Khan, giant papillary conjunctivitis, ये कहाँ से आ गया? What are you attending? Now all of the following are passing through the common, what is this common tendinous ring known as annulus of Zinn? It is present in the base of the orbit or apex of the orbit. If this is the eyeball and this is the orbit, like a pyramid shape, in the apex of the orbit there is a fissures. One is superior orbital fissure, one is optic canal, this one, and surrounding that there is an annulus of Zinn, which is encompassing the middle portion of SOF and optic canal. From optic canal, second nerve passes. Now third nerve, fourth nerve, sixth nerve. From the middle part, the question is always passing through the common ring. The common ring includes the middle portion. Middle portion, remember as NOA. N means nasociliary, O means oculomotor, superior inferior division, A means abducens. So answer is frontal. Why? Because frontal is passing through upper part. LFT, lacrimal, frontal and trochlear. And with superior ophthalmic vein from the upper part, inferior ophthalmic vein from the lower part. And along with the second nerve, ophthalmic artery also passes through the optic canal, along with sometimes sympathetic nerves, postganglionic sympathetic nerves. So that's the anatomy question, but here comes an important the superior orbital fissure syndrome features. It comes from here only. What are the multiple nerves involved? Any etiology in the apex of the orbit, it will push. So it will cause unilateral proptosis in the patient. The patient will have ophthalmoplegia. Because if all the nerves are involved, third nerve, fourth nerve, sixth nerve are in the apex, the patient cannot move the eyeballs. Then because of third nerve, fourth nerve, sixth nerve involvement, and there is loss of corneal sensations. Now corneal sensations are checked. Fifth nerve, nasociliary, is a branch of fifth nerve V1 that is supplying the corneal sensation. So that is a unilateral syndrome, superior orbital fissure syndrome. And along with SOF syndrome, if optic nerve is also involved, means vision is decreased, then the answer will become changed to orbital apex syndrome. That will be 2, 3, 4, V1, 6. Second nerve is extra involved in orbital apex syndrome. And it goes backwards, it goes into cavernous sinus. That can be unilateral as well as bilateral proptosis. Because cavernous sinus can spread to the other side. And cheek sensation will be extra involved in cavernous sinus. So how do you know clinically if cavernous sinus is involved or not? One, bilateral. And in bilateral, the first structure involved is sixth nerve. In cavernous sinus, I hope you know, in the medial side there is sixth nerve. So one problem goes to the other side, sixth nerve is involved. That supplies lateral rectus, which causes loss of abduction of the fellow eye. And loss of cheek sensation in the involved eye is also going in favor of cavernous sinus. So who can give me one example of a cavernous sinus syndrome? I'll give you a hint. The patient is coming with pulsatile proptosis, in, out, with a whooshing sound in the head, after road traffic, after head trauma, with ophthalmoplegia, loss of cheek sensation, loss of corneal sensation, other side also involved, other side sixth nerve is involved. What is that? That is keratico-cavernous fistula. Keratico-cavernous fistula, the orbital bruit is positive because there is a communication between the internal carotid artery and the cavernous sinus. Good answer, Kirti. Very good. Kirti, Abhilasha, दो नाम है आपके. दो नाम है तभी आंसर अच्छा कर रहे हो. Twinkle का एक ही नाम है. Very good. CC fistula से आंसर कर दिया. Excellent. So in which position right inferior oblique is tested? So there are cardinal gazes. 6 gazes are there. And always say, you remember this cross in your mind or in the exam, it will help you to solve many questions in squint. So right inferior oblique is a elevator. So it should come over this one and this one. So inferior oblique is actually a elevator maximum in adducted position of the eye. It causes abduction, but here in adducted position 51 degrees, the eyeball gets aligned to IO and SO. IO is a pure elevator, SO is a pure depressor. And SR comes over here because in abducted position 23 degrees, it gets aligned to eyeball. SR and IR. And LR is an abductor, MR is an adductor. Same goes for MR. This is IIO, this is SR, this is LR, this is IR, this is SO. Please remember, this will help you in solving many questions. So right IO is tested. This position is what? This position when the patient looks left and up. Because in left and up, left SR and right IO are tested. So this is levo elevation is the answer over here. Only melody, the sin rod is just to remember the theoretical actions. This is practical actions, clinical actions by which you solve the questions. By sin rod, superiors are intorters, recti or adductors, you just solve the theoretical question. If one muscle is working in the eye, to solve the actions of the muscle, where the muscle is tested, this is how you tell by making a line diagram like this. And here in this position, there will be maximum diplopia as well. Like if the question is asked, left SR palsy or right IO palsy will have maximum diplopia, answer is on looking left and up in the direction of paralyzed muscle. So left SR palsy, right IO palsy are working in levo elevation. Maximum diplopia also will be in levo elevation in the direction of muscle where it is working. That is how you solve the question in the. So one more question. If I ask the question, in which position you check right inferior rectus? Right IR is checked in dextro depression position. So if there is a right IR palsy, the patient will have maximum diplopia looking right and down. Looking right and down means dextro and depression. Means going upstairs or going downstairs. This word also sometimes they ask. जब आप सीढ़ी के नीचे जाते हो ऐसे ऊपर जाके जाते हो नीचे या नीचे देख के जाते हो. Going downstairs. Going downstairs is looking down. Alright. Okay, next question is one optics. A patient with a +1 diopter refractive error. +1 diopter refractive error means the patient is hypermetropia. Only simple hypermetropia, no astigmatism. There is no cylinder given. And in left also there is hypermetropia +3 diopter. So there is what? The word ametropia. Ametropia means refractive error. And aniso means there is a difference of refractive error. That's the answer over here. What is anisocoria? Astigmatism, there is no cylinder given. Anisocoria is difference in the pupil size. And why the answer is not amblyopia? Because they have not given the visual acuity. For amblyopia, the visual acuity has to be less. So if the visual acuity is less in this left eye, then answer will be anisometropic amblyopia. Here it is only given anisometropia. Now one student asked me today in my group, sir, this is not significant anisometropy. Yes, significant means more than 2.5 diopter difference. This is not significant, but this is an isometropia. Any difference in both eyes is an isometropia. Significant is more than 2.5 diopters. So what is the treatment of this? Spectacles, which are given to the patient. Spectacle is the answer of this anisometropia. But if the vision is less, means the answer is anisometropic amblyopia, then the answer is again spectacle first. Spectacles has to be given. Means refractive error correction. Then if the age is less than 8 years, patching of the better eye. Occlusion or atropenization of the better eye. And video games also sometimes to involve the amblyopic lazy eye. Stimulators are there, not Mario games. Stimulators. Video games are some stimulators. Okay. Now in a child with crossed eyes, now crossed eye means the parents are thinking the child has a squint. It does not mean cross diplopia. Crossed eye means the parents are thinking my baby eyes are not aligned. It is misaligned. The first management in a child squint is you do refractive error testing under always less than 8 years, you do under atropine, that is the strongest cycloplegia. So there is a method. This is R. There is a comitant squint. If there is a child, mostly it is a comitant squint, mostly. Refractive correction. O. Occlusion, less than 8 years, if there is a strabismic amblyopia. O. Orthoptic exercises, some fusional exercises are there. Then O. Operation. The concept of operation is same for adult and children, comitant paralytic, and prism therapy is also given. So I know many people must have answered the question patching, that is wrong. Refraction under atropine is the first thing for any squint in a child. Now a 66-year-old patient came to the clinic with peculiar complaint of the edge of the table seems uneven sometimes. The doctor did a couple of tests by examining the eyes, one of which is shown here. So this symptom is also very important. Means distorted images are seen. That is known as metamorphosia. And the patient is old patient. So old patient with metamorphosia suggests something is there in the macula, central retina. Macular problems can lead to distorted vision. And let us see what is the investigation given. This investigation is given as optical coherence tomography, in which this is the last layer of the retina, retinal pigment epithelium, and the inner 9 layers of the retina is neurosensory retina. And all the 10 layers of the retina are separated from choroid. This is not retina detachment. This is not retina detachment. In retina detachment, the 9 layers are separate from the 10th. Neurosensory separate from RP. This is a sign known as pigment epithelium detachment, which is seen in old patient with metamorphosia. Answer is age-related macular degeneration. So question was asked which is true. Now Amsler grid is done, yes, but Amsler grid is not an objective test, it is a subjective test. Patient will tell whether he is having metamorphosia or not. Answer is outer retinal layers are involved, because here the drusen's age-related end products are deposited under the RP layer in the Brooks membrane. That is the answer over here. And this condition is not observed, you have to treat. If it's a dry RMD, you give oral antioxidants. Vitamins are given. Omega-3 fatty acids are given. Zinc, copper is given. And in wet RMD, intravitreal injections, photodynamic therapy is given. It is not spontaneously resoluting. The condition is not observed. You have to treat this condition. Now, who can tell me this pigment epithelium detachment can be seen in which RMD? Dry or wet or both? Dry, wet or both? Answer is both. Can be seen in dry, can be seen in wet. What is the difference of dry and wet? Which vessels grow in wet? Choroidal new vessels. If the choroidal new vessels grow, that is a wet ARMD. Okay, good. Now I know many students must have answered this question wrong. Let us see how. The question was, all of the following are optic disc changes in a patient of glaucoma. Now in glaucoma, what happens if this is a normal optic disc? This is a cup. Cup is not a structure. The main thing is this neural rim, which is formed by the nerve fiber axons, and when it forms a depression, that is a cup. Now in glaucoma, there is a loss of ganglionic cells. So loss of ganglionic cells means loss of nerve fiber axons. So there is a thinning of the neuroretinal rim. So that is true, causing increase in the cup disc ratio, and when it is more than or equal to 0.7, it is abnormal. Then the vessels are shifted towards the nasal side, because nasal, there are radiating fibers of the retina, they attract the vessels towards their side, so there is the nasalization of vessels. The vessels are bending and coming out of the optic disc. That sign is known as bayoneting sign. Now this seedless scotoma is also seen in glaucoma, yes, but this is not an optic disc change. This is a visual field change, and that is the answer over here. Good stress tree. It is a visual field change, that is the answer. What is the first visual field defect in glaucoma? If we just quickly revise, the first visual field defect is, if this is a visual field of the right side, this is blind spot, the first visual field is paracentral scotoma. That is the first visual field defect, not the first visual field change. The first visual field change is isopter, means visual field contraction, not involving the blind spot, means bearing of the blind spot. Then this is cedral scotoma, when it joins the blind spot. Then arcuate scotoma, when entire arcuate fibers are involved. Then double arcuate scotoma, if both arcuate fibers are involved. Then in the nasal side, ruinous step is there. It is not a defect, it is seen in ruinous nasal step is a finding in double arcuate scotoma, like ring scotoma. Then central fibers are lost. And then temporal. The last is temporal fibers, because radiating fibers are the most resistant to glaucoma. So first defect is paracentral scotoma. Then cedral scotoma, then arcuate, then double arcuate, ruinous nasal step, central scotoma, temporal scotomas. First defect is different thing, first change is different thing. Next, now trauma question has been asked multiple times. A 12-year-old boy has suffered orbit injury with a cricket ball, means we are talking about blunt trauma. In FMGE, this question has been on multiple times. Next day, diplopia is there, more on up gaze. And there was headache, dizziness, vomiting looking up. More diplopia looking up. Also develops bradycardia and hypertension. No congestion, no proptosis. Answer is what? Answer is floor fracture, which is known as blowout fracture. That is a maxilla bone fracture, because that is the weakest point of the orbit. And the orbit contents are dropping down like a teardrop sign. Which muscle is entrapped? Mostly inferior rectus is entrapped. Entrapped means it is a paralytic or restrictive squint. It is a restrictive squint. That's why patient has more problem looking up. Now in IR palsy, patient will have diplopia maximum looking down in the direction of paralyzed muscle. But if IR is entrapped, restrictive squint, there is more problem looking up. And bradycardia, why? Because oculocardiac reflex. Sensation, fifth nerve supplies send impulse to 10th vagus, decrease heart rate. So IR is entrapped as a restrictive squint. Who can tell me force duction test will be positive or negative here? In restrictive squint, force duction test will be positive. If you try to pull the muscle, you won't be able to pull, because you will feel the restriction. That is a positive test. In paralytic squint, you can freely move the eyes. That is a negative test. And teardrop sign, of course, is there. Now, a 10-year-old boy presents to outpatient department, complaint of itching, foreign body sensation, shield ulcer. Now, itching is a prominent feature of allergic conjunctivitis. And conjunctivitis in a 5 to 10-year-old boy, shield ulcer, friction ulcer. Why? Because of conjunctiva papilla. Means the answer is vernal keratoconjunctivitis. It is an allergic response. Type 1 allergy is more than type 4. It is 1 plus 4, one answer is more. Topical antihistaminics are given, also known as spring catarrh. Does not happen in springs. So papilla sometimes can be giant papilla more than 1 millimeter. Now if the question is everything is itching, foreign body sensation, shield ulcer, papilla because of sutures or contact lens, then the answer is giant papillary conjunctivitis. So papilla goes in favor of itching, goes in favor of allergic conjunctivitis. So young boy, summers, mostly comes in summers, that is vernal keratoconjunctivitis. Horner-Tranter dots can be there. Horner-Tranter dots are eosinophils, mast cells over the superior limbus, white dots in the superior limbus. Comparison to Herbert pits, that is depressions, follicles, heals in trachoma following Herbert pits, that is brown black depressions in the upper limbus. Yeah, Techi is asking very good question. Maxwell Lyon sign, ropey discharge, thick discharge can be there. डिस्चार्ज भी किसी ने अपने नाम पे दे दिया था, मैक्सवेल लायन ने अपने नाम पे दिया था, मैक्सवेल लायन साइन इज ropey discharge. Now 5-month-old child with whitish foamy triangular lesion in conjunctiva. All of the following are, now this question has been, many people say it's my question, some say my question. What is it? It is, picture is not there, but it is a Bitot spot. Why? Bitot spot is a foamy appearance because of a bacteria. Which bacteria? Cornybacterium zerosis. It is due to vitamin A deficiency. That is also true. More common in temporal conjunctiva. Why? Because goblet cells produce mucus, and goblet cells are maximum in nasal conjunctiva. That's a deficiency, and vitamin A is important for goblet cell function. That's a deficiency is more in temporal conjunctiva. And answer is D. Why? Because it comes in X1B stage. Who can tell me what is X1A stage? What is XN first? XN is night blindness, nyctalopia, early feature. X1A is conjunctival xerosis, dryness of the conjunctiva. X1B is Bitot spot. X2 is corneal xerosis. X3 is keratomalacia, A, B, less than 1/3, more than 1/3. S means scarring of the conjunctiva. And F means fundus, retina changes. Because of rods are not also functioning because of vitamin A deficiency. Now it's the most common cause of vitamin A deficiency. What are the features? In eye known as xerophthalmia. It's the most common cause of dash blindness. Don't say preventable, don't say night. It's the most common cause of childhood blindness in India. It's the most common cause of childhood blindness in India, vitamin A deficiency. That's why it comes as a PSM question. So PSM people say it's their question because blindness word comes. Biochemistry says it's our question because vitamin comes. Pediatrics says it's our question because child comes. Ask them staging, they say refer to ophthal. Then there's ophthal question. Even biochemistry people say vitamin is there. It's their question. Everyone is fighting. We don't fight. Take it. Doesn't matter. Okay. Now 18-month-old child was taken, again a pediatric question, 18-month-old child. Ophthalmologist is exhibiting a white reflex, that is leukocoria. Now leukocoria, most common cause is congenital cataract. Ultrasonography revealed an intraocular mass. Now intraocular mass is present. Now this I have corrected already. The answer is retinoblastoma, not PHPV. PHPV does not have intraocular mass. Toxocara, choroidal melanoma. No, choroidal melanoma can have intraocular mass, yes, but child. Choroidal melanoma is the most common intraocular tumor in adults, but it does not have calcification. Calcification word, rosettes, synaptophysin. Acha, dermatology also have told that this is their. Why? Dermat में कैसे आ गया है? Dermat लोग क्या कर रहे हैं इसमें? पता नहीं. So synaptophysin, chromogagnin. Patho question. Synaptophysin, rosettes, chromogagnin in a child with a mass, calcification, rosettes, leukocoria, all goes in favor of retinoblastoma. It's the most common intraocular tumor in child. Most common intraocular tumor in adults is choroidal melanoma. So treatment depends on the staging of retinoblastoma. If you know groups and staging, you should know about that also. It's corrected already. The answer is retinoblastoma. Now again, I told you videos are not asked in the exam, but this is like a videography question. That on examination it was noted that the upper eyelid did not follow the eyeball in down gaze. I know looking at the down gaze, many must have answered the question Munson sign. Now that is seen in down gaze, yes, but Munson sign is the bulging of the lower eyelid in down gaze in keratoconus. That is not the answer here. Now normally what happens, our upper eyelid follows the eyeball in down gaze because the LPS muscle relaxes and follows. But when it does not follow, it is not that it is lagging behind. The name says it is lagging behind, it is lid lag sign. Can be seen in thyroid eye disease because of eyelid retraction. It will not follow. Can be seen in congenital simple ptosis. Only two conditions. Rat lo dobara. Buri tarah rato. Congenital simple ptosis and thyroid eye disease. Bolo dobara. Congenital simple ptosis and thyroid eye disease will have lid lag sign. Seen in down gaze. Eyeball comes down, eyelid will not follow, eyelid lags behind. Congenital simple ptosis, because of LPS muscle is maldeveloped, it cannot relax in down gaze, and thyroid eye disease because of eyelid retraction. In thyroid eye disease, it is known as von Graff's lid lag sign. No specs classification in thyroid eye disease. Very good. Teaching. What is lag of thymus? Lag of thymus is seen in seventh palsy, Bell's palsy. That is inability of the eye to close in primary gaze. Inability of the eye to close in primary gaze because of orbicularis weakness. Orbicularis muscle closes the eyes. Orbicularis closes eyes. So patient is not able to close eyes in primary gaze. And epicanthus is the extra fold of skin coming from the upper eyelid. That is the one liner. Epicanthus can come from the lower eyelid also. Then it is known as epicanthus inversus. Now, a diabetic patient. One question on diabetic retinopathy is also very important. A diabetic patient presents with complaints of blurring vision, underwent cataract surgery 1 month ago. Fundus angiography is shown. You put a dye in anticubital vein, it goes to heart, it goes to retina choroidal vessels, and there is a leakage. Means it is a central hyperfluorescence in a flower pattern. This is a flower petal appearance, and that is classical of cystoid macular edema. And after cataract surgery, if there is a cystoid macular edema, the answer is known as Irwin gas syndrome. Can be seen in diabetes also, can be seen in after cataract surgery also. Very difficult to differentiate for your level. But in CSR, it will be ink blot appearance. So in OCT, there will be thickness of the central retina will be there because the edema is there in the macula. Cystic spaces will be there in the macula. So in OCT, you will see like this. There will be cystic spaces in the central retina. Achha, if you get a OCT picture of the inner 9 layers, the neurosensory separate from RP, then the answer is central serous retinopathy. That is the central exudative retinal detachment. And if all the 9 layers, all the 10 layers are separated, then it is a pigment epithelium detachment that is seen in ARMD. And macular hole in OCT will be a discontinuity in the central retina. This just only for identification, idiopathic condition, macular hole condition. Ink blot smokestack appearance in CSR. In CSR, wait and watch for 3 months. If it does not resolve, then photodynamic therapy after 3 months. Cystoid macular edema treatment depends on the cause. If it is after cataract surgery, NSAIDs or steroids. Same answer for uveitis. If it is after diabetic retinopathy, very important. Any stage of, listen to me, very important. Sun lo sab log. Everyone listen. Any stage of diabetic retinopathy can have cystoid macular edema, whether it's a very mild NPDR or proliferative stage. Answer of cystoid macular edema in a diabetic retinopathy is intravitreal anti-VEGF injections. If only very mild NPDR question comes, only micronesomes are there, then wait and watch. Only diabetic control. But in very mild NPDR with CME, anti-VEGF injection is the answer. If answer is only PDR, proliferative stage of diabetic retinopathy due to new vessels, then answer is pan-retinal photocoagulation. Secondary is anti-VEGF injection. But if the question comes PDR with CME, then answer primary is anti-VEGF injections. So if CME word comes in diabetic patient or retina venous occlusion, CRVO, BRVO, answer is anti-VEGF injections. And various drugs can cause CME. Name some. Prostaglandins, myotics, adrenaline in aphakia patients, and high doses of niacin. Again, prostaglandins, myotics. That's why prostaglandin myotics are pilocarpine are contraindicated in uveitis. because they increase the inflammation in the eyes. Adrenaline in aphakia patients and high dose of niacin. If drug is the cause, stop the drugs. Identification of the cataract is very important. Cuneiform is the most common senile cataract, in which there is a wedge-shaped cataract in the periphery, like a wedge-shaped cataract. It is a cortical cataract. Rosette cataract seen in blunt trauma, like a star-shaped cataract. Snowflake cataract seen in diabetes mellitus type 1. Morgagnian cataract is the answer. This. In Morgagnian cataract is seen in old age, that is hypermature senile cataract. Hypermature senile cataract, the lens become very small in size. If the lens become very small in size, what happens? This yellow is a nucleus. Nucleus can fall down. This is a cortex. Cortex liquefies and the nucleus falls down inside the lens. That is hypermature Morgagnian cataract. Now this can lead to which glaucoma? My last question for today. Which glaucoma can be seen in Morgagnian cataract? So in Morgagnian cataract, phacolytic glaucoma, very good. Also known as lens protein glaucoma. The lens size is already small, shrunken, nucleus has fallen down. So lens protein is coming out and blocking the trabeculomeshwar. So it is a secondary open angle glaucoma. When do you call close? When the iris blocks the angle, then it is a closed angle. So secondary open angle glaucoma, that is phaco means lens, lytic means lens is lytic, also known as lens protein glaucoma, seen in hypermature Morgagnian cataract. In comparison, you have to compare with intumescent cataract when the lens is swollen. Tell me this answer. Which glaucoma can be seen in this? When the lens is swollen, intumescent cataract will lead to pushing of the iris, closing the angle, secondary closed angle, known as phacomorphic glaucoma. Morphology of the lens is changing. So phacomorphic, shallow AC. Phacolytic, deep AC. Why deep AC? Because the lens is very shrunken, very small in size. The entrechamber is already deep. Phacomorphic will have shallow AC. Phacomorphic, closed angle. Phacolytic, open angles. Achha, who can tell me? What's the management of phacolytic or phacomorphic glaucoma? Answer is same. Management is cataract surgery. You do cataract surgery but with IOP control. And who can answer? Management is cataract surgery under IOP control. And if you don't control IOP, what can happen? What is the most dangerous complication of cataract surgery? If you don't control the IOP, what can happen? Expulsive suprachoroid hemorrhage can happen. If you don't control the IOP, sudden fluctuation of IOP will lead to suprachoroidal hemorrhage, which can expel everything outside the eye. That is expulsive suprachoroid hemorrhage. Kirti Abhilasha, very good answer. So that's the 20 questions. And I told you more than 15 questions. If you have done correctly, that is okay. And I have given a poll also in my channel. Let us see now how many of you have got how many corrects in the poll. So I gave this poll, 5% is less than 10, 40% is what, 11 to 15, 50%, and some have got 20 out of 20. Out of that one is I am one of them because I just clicked on that, and 50% is more than 15. That is a good number. 15 more than 15 is also a good number. 19 corrects is very good. Alright, any questions for me? Let me know. I have 2-3 minutes. Good. And there is a quiz going on. I hope you are doing the quiz. Those who are not in the quiz, they can join the quiz. The quiz is this one. There's a quiz going on. You can join the quiz. And we are done till glaucomas. Next topic is eyelids. And we'll do some grand quiz and image weight quiz and previous year questions quiz also as the exam approaches. Alright, logmar and NEET details are same. Alright, thank you very much. Thanks for listening. Best wishes. Proptosis in capillary hemangioma can be there. If it's an orbital hemangioma, it can cause proptosis. Primary angle suspect, primary angle closure suspect, you are asking Harsimran. Everything is normal in the eyes, normal IOP, normal optic disc, normal visual field, but the angle is closed or occludable. Then you answer PACS. Thank you. Sympathetic ophthalmia, better answer. Sympathetic ophthalmia, Kalake Om, the answer is intravenous steroids. If there is no vision potential in the traumatic eye, then to prevent the ophthalmia in the other eye, then enucleation is answered. Otherwise, intravenous steroids.